And as we look at newer technologies, and I was reminded of this, actually Mike Jansen gave me this slide originally. When we have new technologies, we should always remember Scott's parabola. Everyone knows that? Christoph, do you know this? So it's from British Medical Journal 2001, promising idea. And there's this very significant upslope, and especially in the US, we're very strongly affected by that. And what can happen over time is that we basically have a decrescendo, and what we don't understand is this interaction of more or less complications have a kind of a phase shift emergence that then looks like they're far more common than what they actually are, and simply a reflection of the percentage of procedures done. So this is Scott's parabola. It's mathematically clear. The end result is that a standard treatment that actually could be working under the influence of increasingly publicized complications leads to doubts creeping in, and then first reports that are problematic, and then authorities come into the fray and protect the public and put in regulatory restraints, and then devices fall into disuse and people talk about how good it was. So I can give you one little example, and that's the Fernstrom balls. The Fernstrom balls actually got a really bad rap, and I heard you talk this morning, Amir, and please come up here. De facto, at an IMAST meeting in Munich many years ago, I actually saw this microphone's on the end of its battery life. It's going to phase out pretty fast. They were actually looking at the results of survivors by a guy named Mackenzie from Canada, and they were actually not that bad at all. And most amazingly, one of the surgeons in the audience had a 2-level Fernstrom cage put in, and he had not had it imaged in a long time. Lee, this computer's gonna, by the way, go out in a second. It's on super low battery. Oh, the solution is right there. So the end result was that they actually did far better, and he had not been imaged. We had a C-arm there, and he had his spine imaged, and the surgeon sat in the audience, and the 5-1 cage was in the sacrum, and he kind of commented on that. The 4-5-1 actually still worked surprisingly well. So not all is so bad, but we get kind of perception. So Scott's parabola was well educated. Another round of applause. They didn't hear it before. So Mike, I'm showing you old Scott's parabola slides. Remember those? You gave me those. So disc arthroplasty is right in this. So I just wanted to start with a case of mine, and I have 2 cases to just have everybody get involved. And that is a cervical disc arthroplasty, and all questions are fair game. And again, always keep in mind the Scott's parabola. The second entity is something we haven't talked about in this session, because none of the companies that have them sponsored this meeting here, and that's Interspinous spacers. So this is a 45-year-old female, and she has a 3-level spondylosis, 4, 5, 5, 6, 6, 7. She had neck pain, right arm and hand weakness. And now this is the kicker here. She had significant psychological factors which we dutifully identified: ADD, panic attacks, anxiety. She had smoked, and we actually treated her for a year non-surgically. And the most relevant thing is that her father had a series of surgeries for his neck, and he had a 3 set of ACDFs done, redone, and redone, with a very mediocre kind of healing result of a C4 to 7. So his neck is kind of tilted forwards. And she's unemployed and a former nanny. So we have a pretty significant right central lateral disc herniation at 4-5, a moderately large spondylosis at 5-6, and a 6-7 spondylosis, but no clear neurologic correlation. So Christopher, I'll come to you, Christoph. So you've shown endoscopy quite nicely. I'll just point to it. If you were to somehow think that the majority of the patient's symptoms in this setting equal neck pain and arm symptoms, negative EMG, come from that 4-5 disc, is this disc still something that you'd be comfortable fermanotomizing?
I think for me, this is really a difficult case to understand how it fits together. So do you have any more information on the area, on the dermatome of the pain, and what muscle group is weak?
We had 2 EMGs that both were negative.
So she has no defined, it's not like the deltoid is weak on one side.
No.
So
this is a multifocal radiculus syndrome, I would call it. And again, the arm, hand pain is kind of not very specific, but it's repetitive. She's had injection selective nerve root blocks, extensive traction, changed therapists twice. We didn't like the initial therapist's work.
And any of the diagnostic blocks had any?
We had 3 levels, and again, there's pain reduction or pain relief with all, but the typical kind of an anesthetic effect after 48 hours, and then a mixed bag of things. Happy for a while, then coming back that everything was back to baseline.
Because I'm not at all impressed by the central stenosis. There's no T2 signal change. I'm also not impressed by the foramen. The foramen is widely patent at 4-5 up there. You know, if you look at the foramen on the axials, and one thing that we've started now, we always get the sagittal obliques, the films, which I think really, in some cases, a game changer. I think anybody who operates on the neck and you look at the foramina, getting those obliquely oriented sagittal images are just a game changer. Because within the foramen, the pathology is so different. If sometimes the nerve root just gets, hooked by the tip of the SAP, right, in the foramen as they go out there. I really don't see pathology to treat in this patient, so I wouldn't know what to do. And endoscopy is not. You cannot get disc that is. You always see the spinal cord there, but the spinal cord is only filling up a little bit of the thecal sac. So you would never get that, you would never get stuff that is in front of the spinal cord with an anterior approach. And I don't do, as a posterior approach, and I don't do the anterior approaches. But really, regardless of that, she would not be a surgical candidate for me, no matter what.
Always a good answer in these kind of questions, because thicker things are coming. Neil, volunteer your thoughts. Microphone.
So just from the perspective of discussion, we published a paper in JAMA, Jens, and this lady has 3 of the predictive erosive patient characteristics that will predict a more difficult outcome. So she's Medicaid, she's unemployed nanny, she's nicotine, and she's psychological. So if we follow that prediction modeling paper's recommendations, the calculator would calculate somewhere in the area of 33% or lower likelihood of success.
So what do you do with that kind of patient? You tell them to just...
Is that for neck pain or back pain?
That was for spine fusion.
Spine fusion. So if I told this lady you thought that was a little bit, that had these panic attacks, the primary goal is to try to help your arm pain and decrease the numbness, and I have no idea if you get neck pain, that's probably going to happen anatomically. So why would that affect whether she smokes or not smokes, or her father's had this other surgery, or whether she's on Medicaid? Or is it that we're not giving them realistic goals on what to expect?
So my answer to that is that if the patient characteristics influence the outcome independent of your surgical skills, refining your surgical skills greater and greater will not likely deliver the delta that you're looking for. So I'm just voicing caution under the circumstances.
But isn't your goal just to help her with her weakness? You think she's going to fake the weakness when she comes back because she's crazy? And therefore it's a bad outcome?
So this patient did not have identifiable motor deficit, correct?
It just says right hand weakness. I assume she did.
Negative EMG.
Negative EMGs. But she drops things. She says that she can't do her daily functions. So.
Yes, is that the cruise signal in the cord? Axial? Is that a cruise signal?
That's a great question. Is this a true cord signal change? The radiologist read it as positive. She did not have myelopathy, long track spasticity signs whatsoever. She's obviously a difficult patient. We did not jump on surgery on her. I actually personally followed her for, I think, over a year.
Well, I think that's a good question. We all see these patients that we know wouldn't do as well as others because of psychosocial things, but, what do you tell them?
Let me pick on Trent, who rejoined us. So this is obviously a difficult patient, quite obviously. She's actually seen a number of practitioners in the greater area, and she's now with you. Pass, punt.
Pretty sure I did a 3-level fusion on her because I like a Raptor F-150, and they're not free. No, I think there's a couple things here. Number one, an EMG, do we really need EMGs? So sometimes your nerve root has to be damaged enough to be picked up on the EMG, so they can come in with pain and their EMG may be negative. She doesn't have a motor weakness, although she claims she has some weakness once in a while. Pain is something I think is important. I kind of disagree with my colleague, Christopher. There's some right foraminal stenosis there, absolutely, and I think that should at least be considered. You'll see this high signal, I think, is a little bit questionable. You'll see some signal in the axials on both of those, on all three of those little cuts there. You don't see it. I don't see too much of it on the sagittal, but maybe that's just because it's a small picture. If this patient fails conservative management, has done well with some local blocks, there's 3 levels there. I think it'd be reasonable to do surgery on. How about that for an aggressive neurosurgeon?
Love it. Now give us some specifics. 3-level ferminotomy, 3-level ACDF?
Hell no, I'm going to do a 3-level fusion.
3-level fusion.
With a plate.
With a plate, okay. All right. So here we got 2. Do you want more contrasting opinions or what? Let's ask other colleagues. What do you want to do?
Yes, thank you. No, all the comments, all make sense. I am a little bothered by the look of the spinal cord on all of those images. Even on the sagittal, you see a signal running all the way through. I'm not sure what that means to me, especially in this patient whose whole history seems a little not standard. But I do think she's got some stenosis there and some foraminal stenosis on the right, at least on those 2 images at 5.6 and 4.5. 6.7, I don't think we have. I don't know if that's a foraminal image, a slice, an axial through the foramen or not, but certainly at 4.5 and 5.6. And I think at some point you have to put it back a little bit into the patient's realm. You've done everything else that you can do for her. This is where we are. What do we have left? We can try something surgical for you. And then you got to stick it back to her a little bit and say, look, I don't know. Some people I could tell you there's a 90% chance you're going to do great. You're not one of those. You're down in the 50-50 range. What do you want to do? So we got to put it back to them a little bit, and it would be a fusion. It would be an ACDF for me.
ACDF, 3 levels, 2 levels?
2 or 3 levels. I'd want to see a little more 6-7, but.
So she's adamantly, just a very reasonable thing, she is adamantly against that. So this is one of the things, she actually had a 3-level fusion here, totally within the community here. There were several surgeons who offered a fusion. She does not want it.
I would agree. I would like to see a little better at the 6-7 level, because I would consider maybe just trying to minimize it. And
So 2-level fusion? Or?
yeah, possibly. Maybe, I'm not convinced she's that tight at 5.6 either, but so could you get away with just going after, I don't know. It's
Great question.
Yeah.
Okay, now we have a couple of gentlemen here from this row down. All of you, I'm watching every one of you, whether you're a doctor or representative, you have to vote. You're the tribunal. And then we'll have the appeals court with Dr. Jansen and Dr. Ziegler who render their final verdict. So, further non-operative care doesn't work. The medical director of the Apple Health Plan is totally frustrated because she's had everything and she's written complaint letters, so you have to decide on something. Further non-operative care is not going to fly. It's on the patient's shoulders. Who wants to do a fusion? Just any levels. I'm watching all of you guys. You're the 2. Who wants to do a disc replacement? We had a motion-preserving course. Show of hands. Nobody? What do you want to do? Bilal, you're from Israel, Jerusalem, Hadassah.
I wouldn't do for her surgery.
I'm pushing you. She's with you.
I will try not to do surgery in this case.
Ben Shell, Dallas, Texas.
Just a decompression. I would do as little as I could to try to not necessarily avoid complications, but I would try to address the arm pain, counsel, foraminotomy, yes, to counsel her about her neck pain, to appease the anxiety, the panic attacks, and try to avoid further complications down the road, foraminotomy.
So you just want to do an annuity, so you can do a second surgery. Is that the reason?
I'm hoping that she'll find her way to Denver, Colorado, and or back to my hometown of Dallas, Texas.
Rhinoplasty, you did a beautiful job with that.
I think I'd approach this from the front to level 4, 5, 5, 6, and just, advise her again, for arm pain.
Observing course or traditional?
Traditional, I still
He
do.
doesn't buy it. You're fired too. Eric.
I think we've all discussed that surgery is most likely going to fail, not necessarily from a technical standpoint, but from an outcome standpoint. I think there's a general consensus here that even if you were to partially improve her hand weakness, I think the odds are she'll still complain pain. I think she'll be unlikely for the psychosocial reasons mentioned here, especially without a home run in terms of pathology. I think if you did anything less than a fusion, there would always be some questions, some doubts, and she would go on and get a fusion after the arthroplasty. So I would do a 2-level fusion, do a definitive surgery, and then when that doesn't help her.
Stage of 180 on 6'7". So we had New York.
Can you help me understand why you think that she's going to ultimately end up with a fusion just because you did a disc replacement? I'm confused.
I think there's a high probability that she's going to be unhappy, again, for the psychosocial reasons. I think.
So is it the rule that if you do a disc replacement and the patient still hurts, you convert them to a fusion? If you do a fusion and they still hurt, you say, well, sorry, it didn't work, because we're used to doing it.
Well, I think,
I'm just trying to help understand why you picked one treatment over the other, because you think one's better.
I don't think so. If you do a disc replacement, there could be some questions about whether you did an adequate foraminotomy, whether and more importantly, whether there's some component of dynamic instability that's irritating the nerve root. Again, these are soft, hand wavy type measures, but nevertheless, that's how some people think. I think if you do a disc replacement, you may not offer her one, but I think she'll shop around, she'll still be unhappy, and she'll ultimately find someone who does it, and may not be the best thing for her.
So we've had New York, Dallas, Maryland,
Detroit. I'm still in the fusion camp as well, but in the spirit of the motion preservation course. I think that if you did a total disc, if you go 4-5 total disc, again, it's the pathology, like you said, is nonspecific and it's kind of all over, but that it seems to be on MRI where it correlates the most.
All right, so we've had two high-level experts offer diametrically opposed thoughts. We had the general review panel here be not very in agreement.
So yeah, one more thing here. I always like to understand the pathology, and I think that's why I'm situated where I am. So for me, in the end of the day, the EMG is negative a couple of times. I think the pathology is not in the nerve root, at least not for the weakness, right? Can we all agree? I mean, if she's weak, if she's weak because of radiculopathy, the EMG would pick it up. I mean, it does. It has a very, I mean, the sensitivity is not great, but if a true weakness, it would pick it up. So it's not from the foramina, all right?
That's not necessarily true. You have weakness, but then you also have fatigue.
No, but wait a second, I'm not done yet. Okay, so if you have true radiculopathy with a let's say 4 or 5 is where it is, then you would have a deltoid weakness. At least you would have something in EMG. We don't have that. Okay, so scratch that. At least for right now. So what you're left then with is that she pretends she has some secondary gain or something else, or, like Mike said, maybe it's real. Maybe she really has something. And then one thing that we have seen, we are actually doing a lot of imaging with ultrasound at the university because I have a big DoD grant for that. And one thing, it's gonna totally not officially yet, but what I see sometimes with these patients, they have temporary occlusion of the anterior artery from that disc bulge. So the anterior spinal artery is temporarily occluded when they move a little bit. And the question, and sometimes in these patients, I really wonder if they have almost like transient spinal cord ischemia, which could explain then those symptoms. I mean, that's totally hypothetical. And for that reason, I mean, opening the foramen there would not help. So then a disc replacement would help for that, but I don't have any whatsoever evidence for that. So.
All right.
I've heard a couple people talk about just two-level surgery at 4, 5, 5, 6. I'm a little bit bothered by that retrolisthesis at 6, 7. And so that would kind of make me want to do kind of an all-or-nothing approach for this patient. Just the thought that I had that hadn't come up yet.
If you're in for 1, you're in for 3.
All right, so then we have, so the Washington State Neurosurgical Society disagrees totally. The Washington State Orthopedic Society with Dr. Tomei and Dr. Schonard has the word.
Oh, boy. I'm uncomfortable. And the reason being, it's the non-localization of the neurologic deficit. You know, if the hand is weak and the lesion's where the deltoid lives, I have a tough time jumping 2 levels. And the incidence of arthritic change that is age-related has not been bothering her up until the manifestation of the compression. So really, the only thing that makes compressive sense is the C4-5, but it doesn't make anatomical sense. And I'm not used to operating when things don't make sense. So I'm going to have to pass this back to another.
So no decision.
Yeah, I think it depends on the surgeon's appetite and stage of his career. Because as a junior guy, I think this patient gets a 3-level fusion. As a senior guy, this patient gets no surgery. She does not have clinical myelopathy. She does not have clinical radiculopathy. She's not overtly unstable. So she has no absolute indications for surgery. And she's got other baggage that you're worried about. So you could do the world's most wonderful 3-level anything on this lady, and she comes back in 6 months and it's exactly the same, and your disposition is then going to be what it could be today. So at my stage of career, I would say no deal. No, because if you're in for 1, then you got to do all 3. You can't do a 1-level fusion or a 2. You've got to do all 3, and that's a lot of surgery for somebody with the very soft indications. So I would say no deal.
So would you take this patient to Cyprus and offer her a totally off-label hybrid?
Who's gonna pay for it?
She's fallen onto money.
It doesn't matter. Absolutely not. I will.
Both families' father, for some reason.
You know what I would do? I'll send her get a pain pump. Come back in a year. If she's still weak after your pain pump, then I get a full neurologic evaluation. Make sure you don't have something else going on, and then we'll talk. That's what that would do.
Once you put her on a pain pump, she's on it forever.
They won't cover it.
They won't go away. Mike, we need some constructive help.
You know, I don't know. I think the key here is you have to really decide if you like the patient, because these patients will stick around with you for a long time. I also realize that this 45-year-old patient has radiographic changes that far exceed her chronological age. And sometimes those are symptomatic and sometimes they're just age-related. You know, I probably would see her back a number of times to make sure I like her, because I like to pick the right patients with the right personality you're going to treat. But if I was going to operate on her, yes, I would do a combinations of non-fusion and fusion technologies by definitely putting a disc in at 4-5.
Some of you've always been a star because you're so wise beyond your years, so you combine the youth and the wisdom. And you have excellent hands. You have soft hands, as everybody always says, with a fine touch. What sayest you?
So I feel like this is a patient that I may operate on, but it would, you know, I feel like the EMG is a good one, because if they are willing to go be tortured and come back and stick with it, you know, even if it doesn't show anything, it shows me that they have some commitment. They would have to convince me that they were really symptomatic over months, which it sounds like you did.
She was with me, I think my record's 18 or 19 months before we actually discussed surgery, because there's so many question marks. I mean, it was a no-go when she smoked. So
yeah,
here we are.
I think it's a tough situation. She's got real pathology. I feel like I would operate on her if I felt like she was really invested in getting better, and did so over time.
All right, drum roll.
And you can hit a home run with this patient, because if you make her better, you're going to feel great. But just the likelihood of that is much less than the guy who comes in with a single-level radiculopathy.
The preface of this was Scott's parabola. One of our colleagues had a great question. I just wanted to bring that up. So we did several selective nerve root blocks. Do facet blocks in these patients play a role? Christoph?
That's actually a something really good. I have on my phone, I have this picture of the facet, the referred pain, which I show to my patients. And sometimes you pick them up. You can test them in clinic, it's with hyperextension and rotation. And I think it's definitely a good differential that we haven't brought up. Now, it would not explain the weakness.
All right, can you hit the forward button? Yeah. So I rolled the dice. I did a 2-level FDA-approved ADR at the 4.556 level. Again, this was a substantial follow-up time before that, and the surgery went well. I did use 6mm implants, and then pretty early on, she started to develop this kind of a slippage here.
Yeah, but she's almost auto-fused 6-7 too.
6-7 is almost auto-fused,
So
exactly.
Fused, and then once it became stiff, you have an unconstrained, or it's got some constraint with those pegs device, and so therefore it falls into kyphosis.
So I was thrilled in the beginning. I had a smile bigger than Jack's smile right now on my face. Jack, you're a connoisseur of these kind of finities. Is this a device thing? Is this a surgeon failure? Should I have used a 5mm at 5.6? What's going on? Did I overstuff?
I definitely think you made both disc spaces too high. Look at your facet joints are way over distracted, Jens, and the heights are 50% more than the ones above. So I don't know that a smaller size would have made the outcome any different, but it's definitely over-heighted.
How about the constraint of the prosthesis? Not to pick on any one, but we're learning which prosthesis work for different things. This one has a mobile plastic core, so it clearly has less constraint than one that's a fixed polyethylene and rolls over the dome. And if you would be able to control the motion above the fusion with a more restrictive device, you think you'd still see the same thing. I don't think so.
Yeah. So how did the patient, yeah, exactly. So we informed her of this, and then she had a fall in a shower 14 months afterwards. Nothing particularly violent, but she came to clinic with tears. We always get the x-rays first. I was shocked when I saw them. I was thrilled beyond belief that she had a intact neuro exam, but here we have la fait accompli. Trent, give it to me straight. I did an ADR. I didn't heed your advice for a 3-level fusion. You're known to be rather candid, so feel free. Surgeon, I was
actually going to support you. Here, let me grab that. I was actually going to support you on that first one when you showed the 2-level artificial disc. What's tricky, we can get by with single-level disc, but when you do those 2-level disc, you'll be surprised that you kind of have to put, you have to distract a little bit. And even that first one you put in, then you put in that second one, that first one that you put in doesn't look as good. So 2 levels on that, and you go back to the original x-ray, looks like she was partially fused already. So that's why I wanted to do a 3-level fusion. If you would have put her in our criteria for the IDE study, she wouldn't have actually made it because she was too collapsed down at each one of those disc levels. And she already has kyphosis there in her spine. So that's why I would have done a 3-level artificial, I would have done a 3-level artificial disc, but they wouldn't let us. So that's why I'd done a 3-level fusion. But those artificial discs, when you're going up to those 2 levels, whether you used a 6 or a 5mm, even when I put in the 5mm, I've looked at my x-rays at the end, I'm like, wow, I've distracted him a lot. That's a pretty big disc on both sides. So I think at this point in time, I'm surprised she didn't have a little bit more of a neurological deficit when she came in. The tricky part is getting that out, but a nice little distraction, partial corpectomy, and then I would have done a fusion at the 5-6 level. The other thing that we kind of talked about yesterday with Jack, there was one of our colleagues that had put in one of these artificial discs next to a Klippel file, and that was one of the ones that had failed. And so some of these discs haven't really been tested next to a fusion. And there's a little bit of a rage of the hybrids, of course. And I'm not a fan of hybrid. I've already said that. But other folks will chime in, especially some of the folks that are married to people with hybrids. And we'll go from there.
Mike, help me. How should I salvage this now? I think you saw the follow-up x-rays with Amir's trigger finger.
This is tough, Jens. I would put some tongs and some traction in this, and I think you'll pop that implate will come off of the bottom of 5, and then you'll be able to get 5 up enough to get the prosthesis out, because the plastic is still sitting with the inferior prosthesis just due to the pegs. So if I was to reconstruct this, I would probably then fix and rebalance these segments, and because of the way the interspinous ligaments are opened up and the hypermobility of the facet joints at this phase, I wouldn't try to get away with anything, so I would probably fix it from the back too.
How many levels?
I would fix them all now, do all 3 levels. I'd take that implant out. I've done this. I've revised some of these just like this and left the superior implant in, and it looks just like that if you don't do something to it now, so then I would take them out and give her one operation that I can say I did the best I can. I'm not gonna do an operation that I think I get away with something, and now I'm gonna try to fix it all.
Christoph, Trent was surprisingly kind to me. Would you be equally kind to me?
Well, I think we all have had cases like that. So, I think in the end of the day, we all get back to the indication. Grafting is all, hand graft is, it's all the same. The problem is and I've had patients like that, then you have a complication no matter what it is, and then you go back how thin the eyes was that you were standing, right? You're still not any better, and now you have an x-ray that looks like shit, and you have to take it back to the OR. So, and then you did it for nothing, right? I mean, you were standing on very thin ice. And so I think this, technically, I think maybe a little over-distracted. I think it's a very mobile, sort of unrestrained disc. But I think that could happen to anyone. So no fingers at all, whatever. But I think the problem is, I think the indication.
I would do a CT, because if 6-7 definitely used, then you don't have to bother. Yeah, I would just do a CT to see if 6-7 truly is auto-fused, and if it is, then you don't have to do anything.
It looks like on the right middle X-ray.
Yeah.
It doesn't look like it's.
I agree, but so I get a CT to see, because then you could restore lordosis enough with both 4-5 and 5-6.
We got a CT, and I think we got an MRI also. I'm not sure I photographed that, but there was no poly extrusion. I was worried about, I would want to make sure poly is not there. So we can just fast forward because we want to get into the labs. So I did a posterior fusion only. I actually got a consent for anterior and posterior. And just like what Mike said, with traction, we got her reasonably well aligned, and then did a posterior reduction. Controversially, I did a tethering of the C4 spinous process to kind of bind her down, but wanted to give her some modicum of mobility to hopefully not have the contiguous disc disease, which her dad had. He came to clinic actually several times. So with that, she actually did pretty well. I followed her for half a year, and she did not visit me for her last follow-up appointment, so I'm going to give her a call. I wanted to see how she's doing. So just quickly moving on, any other thoughts?
You didn't take that implant out.
I didn't take it out. I used it as a fulcrum for reduction and did a solid posterior fusion. I actually used iliac crest graft on her, and to make sure everything was as tied down as possible. My decision-making was clearly, in retrospect, at fault, because I obviously had all the unease that all of the colleagues in the room had. Surgery and no surgery, I totally agree with Bilal. The Jerusalem treatment of nihilism was very much in my mind, but I felt in the end that she had a referable pathology, whether it's an anterior spinal artery syndrome or something that an EMG just doesn't pick up. I will never know. Amir, any thoughts? I mean, I was very worried about her psychology, and indeed what Eric said was true. She was a vulnerable patient, and a silly thing happened.
Just a quick question. I mean, was she doing well before she started to sublux?
Yeah, she had. I was worried. I showed her the x-rays, and I said, I'm not sure that I've seen this like this before. Please take care. No, and she didn't do any extreme sports. I mean, she was more into meditation and just gentle yoga, not like your style yoga, not black belt yoga, but she seemed to be doing quite well. She was very pleased. So the arm pain did go away for all that mattered, but then said shower fall happened, and we're back in the operating room. So just briefly, the second thing is interspinous spacers. And again, one of the single biggest socioeconomic problems that we'll face is spinal stenosis surgery. And the aging of the population is massive, and the divergence of people's activity levels is dramatic. And I think it is up to us to decide what to do with these patients. So this is what the second kind of a brief spotlight the discussion was going to be. I wanted to just talk about interspinous spacers. This is a patient, the brand doesn't matter, but this is a before and this is an after. So we actually got a pretty nice decompression on this patient. He had significant back pain, persisted with that, but that's little wonder, but the severe claudication and stenosis was gone. So just briefly, Christoph, without having a plethora of images here in the interest of time, interspinous process spacers, regardless of the brand, do they have a role in your care with endoscopy, or is this something you'd feel comfortable just to say you don't need a spacer of any sorts?
Yeah. So they have a very specific role. They are removed from the patient and go into the trash.
That's why no company wants to sponsor this.
I just can't understand a cathodic device, what a cathodic device would do in the spine. I just don't understand it. And well, it's going to be. If you really put a device like that in that segment, it's going to be a little bit more cathodic. And so then the next segments have to compensate for that. Also, why would you put anything in there? Just do go back there, you do unilateral over the top decompression, you're done. And that also is, if you're sure that the neural impingement happens in the canal or lateral recess, which you don't know, it could also be a foramen. I don't see any of the foramina, so potentially quite much more complicated than that.
Antoine. Dr. Tomei.
I agree with Christoph. I don't believe in interspinous spacers. I can do a tubular, minimally invasive laminotomy, laminectomy with. I can do the lateral recess, I can do central, I can do foraminal, and it's outpatient and minimal blood loss, and I don't have to worry about that spacer.
So, Neurosurgery Society of Washington, outpatient surgery centers are owned by some of our colleagues. Interspinous spacers are a very popular procedure for a variety of reasons. What are your thoughts?
Well, I would actually agree with all these folks. The whole deal of it is those, you look at some of the implants that were out there, we won't have to name them all, but the interspinous process decompressions. What will happen is people will get very good relief symptomatically from the anesthesia, the steroids, and the implant for a very short period of time. And then what will happen is it will usually collapse down. And I have never put one in, but I've taken about 8 of them out. But there is a big role because people have promoted this. And if you look at the literature and the data, there's quite a bit of good data out there that some of the companies will tell you. And I think that's why it was pushed. If you look at one of the original studies that was out there, it was only for mild stenosis, but they started putting in people that have severe stenosis, and that's where the real problem comes in. If you're treating a very minimal problem with a minimal effective device, then you can probably get some pretty good results. But when you have real bad stenosis, it's not going to help.
It's a great point, and it was also meant for, and again, don't look at the device names or so, it doesn't matter. Decompressions alone actually work surprisingly well, and this is an older study of ours, but we did several studies, and decompressions alone are probably a major factor in getting patients better. Just very briefly, don't read this because we want to finish with the lecture part and get into the labs. Trent is right, the literature, if you look at it, actually doesn't look so bad for interspinous spacers, and graphically speaking, blue being decompression alone, it did look like interspinous spacers look a little bit better by 12 months. So. The patients who benefit have still never been fully identified because we still don't have clear parameters such as instability, kyphosis, facet morphology, or facet fit, lateral tilting, etc. This is, again, one of the most overlooked things that I think our radiologists still have to learn to use better. And the grade of stenosis, again, how well is it decompressed before and after, and what structures have you left in place has not been done. So we have science in spine again, but if we look at operative versus non-operative patients on lumbar spinal stenosis, surgery is clearly better. And again, non-instrumented patients actually did favorably well in general. So instrumentation alone is not necessary anymore. And this is again a case in point, very severely ill 74-year-old male, very significant walking difficulties. 4 or 5 is the area of main concern, 2, 3, and again, He just has a very hard time walking. I know there's a difference in the imaging of 4-5 on the axial and the segmental, on the sagittals, but we felt that he was significantly problematic. Just very briefly, Jack, decompression alone, interspinous spacer. Again, imagine this guy has literally about 1.5 pages full on his problem list on Epic.
Yeah, I mean, we fell out of love with interspinous spacers for subsidence, spinous process fracture, loss of efficacy. So we stopped doing those, but not to confuse them with interlaminar device, which follows a good decompression. So I think good decompression is good. The other one is facet joint alignment. The L23 facet joint is very sagittal, and I think it wouldn't take much of a decompression to destabilize that segment, so I'd worry about just a decompression alone there. But 4-5 is certainly amenable to a decompression alone.
Mike, you haven't mentioned interspinous, interlaminar. I'll group them all together. Post your non-fusion stabilization devices.
I'm not a fan of the interspinous spacers. I've taken a lot of them out, and my partner puts them in, and I take them out. But I'm not a real fan of them. And this patient, if this was my dad at 74, I would make more anatomical and physiological room, and I probably would not fuse him. I would probably just do a decompression, and I think that helps them. When I do a decompression on these patients, sometimes I like to lift the paraspinous muscle over the facet capsule with a bovie, and I think I do an internal rhizotomy and deinnervate that facet joint, and it helps them in addition to the decompression.
I'm not giving you the whole set of data, Kristen. Could you decompress this man? Assume that there are 2 levels that are pretty badly stenotic.
So you think 4-5 and 1-2?
The level count is off because he has 6 lumbar vertebrae. So just assume that there's a significant stricture here, and he has 2 levels. That
Yeah. I think it would be very amendable. The only issue is for me is I would, the 2-3 is easier with a smaller endoscope because you see how those spinal processes are oriented as the facet joints. So you really have to stay away from those facet joints so not to get into those. The small scope is 7 millimeters, so you can get right in the middle in there and decompress underneath it. But that's a little bit more tedious, so it takes more time to do that. 4-5 is straightforward. It takes maybe 45 minutes to decompress it. The joints look pretty good there. A flexion extension would be nice to see. We have right now we have 150 patients that we're following up with those type of procedures. So I think it's a good first step. I mean, a couple patients sometimes, become unstable 2, 3, 4 years down the road that you see them. Percentage-wise, it's probably around 5% what we see.
Simple question, difficult answer. How long would this surgery actually take?
With having some teaching going on. So if it's on time and I do it myself, it would take both levels together 1.5 to 2 hours. If there's teaching, probably 3 hours.
All right. So this is not my case, but one of my partners did a 2-level interspinous, so not interlaminar device, and I was actually shocked to see the patient when I was on weekend call because he actually did very well, but he had severe headaches.
That's at 1-2 now. Now we went to a different level.
He had 2. I pointed out again. He has 6 lumbar. Yeah. So they put the devices into the correct level. I got the CT after this. We got severe headaches, but the walking was gone. The low back pain, interesting, was gone. So I was actually really worried how the patient did. He actually left the hospital, but we do think that he had a dural tear from this indirect decompression. So we left him in place. We rehydrated the patient, and much to my surprise, the patient responded and left. Just wanted to quickly show you how data will enter this Scott's parabola. This is from the NHS, and we always malign the NHS service, but Mike Hutton, who's a very active spine surgeon, he's going to be in Tokyo with us at the ISSC. He did this, and it's an amazing thing. And they have a lot of new data that they're able to put together in a very structured fashion. So this is Scott's parabola in real life. This is the interspinous spacers over time, and you can see how their utilization in the UK came up, and then NICE, the outcomes study group in the UK, recommended against them, and you can see how their use plummeted, and the actual insertion rate has dramatically dropped since then. So the surgeons in the UK have really not not found this to be very helpful. And this is how a clinical real-life practice happens over time. I thought this is pretty good. So with this, I'll hand the microphone off to Jack and Amir to correlate, but thank you all for looking through and working through a couple of more challenging and humbling cases.
What are we doing now?